Hello, my name is Katrina, and today I'm presenting a 27-year-old female with the chief complaint of bloody diarrhea. So some of the things I think this is right off the bat are ulcerative colitis, Shiga toxin producing E. coli, runner's diverticulitis, colorectal cancer, GI bleed, or mesenteric ischemia. So I'm going to go and speak to the patient, get a little more information on what's going on, and she tells me that this has been worsening progressively over the past 3 weeks, especially in the last week. Her stools have increased to 3 to 4 times a day, liquid with bright red blood in it. She's also feeling abdominal pain and tells me that about a month ago she did have an episode of rectal bleeding, but this was self-limiting and she didn't really think much of it. It went away. She does tell me that her pain is a 4 out of 10 on a numeric pain scale, and she feels that it's a type of cramping in the lower abdominal region. She tells me that it worsens when she eats dinner that her mother has made, as her mother is trying healthier meals that are full of vegetables. She does feel a little better when she stays away from those meals, and the pain is intermittent. It becomes stronger when she is using the restroom or right before using the restroom. Doing a family history with the patient, she tells me that her mother has a past medical history of hypertension, hyperlipidemia, rheumatoid arthritis. Her father has a past medical history of hypertension and irritable bowel syndrome. She has a younger brother who is free of any medical conditions and alive and well. On her mother's side, her grandmother has a past medical history of hypertension, hyperlipidemia, and appendectomy. Her grandfather has a past medical history of hypertension and hyperlipidemia and passed away at the age of 87 due to pneumonia. On the father's side, grandma had osteoporosis, passed away at 91 of natural causes, and his father had hypertension, hyperlipidemia, irritable bowel syndrome as well, diabetes mellitus, and passed away at 75 from pancreatic cancer. So going over some childhood conditions, she tells me she was hospitalized briefly for a right ulnar fracture in 2005, and then in 2011, in adult conditions, she tells me she was also had an outpatient surgery of wisdom teeth removal in 2011. Going over a review of her GI tract, the patient tells me that she has not had any nausea or emesis, no signs of dysphagia, heartburn, or belching, no constipation, melena, or hemorrhoids, and she does endorse hematochezia as well as a decrease in her appetite, and she has had a change in bowel movements from daily formed stools to 3 to 4 times a day liquid stools with blood. And then I'm going to assess my patient, and what I find is just a symmetrical flat abdomen. When I auscultate her, I hear present bowel sounds, no hypo or hyperactive bowel sounds. Upon percussion, I do hear mainly tympany, but dullness over the organs. And when I palpate the patient's abdomen, I do notice that she tells me there's tenderness over the lower abdominal region, and I feel no masses on palpation. So I'm going to go to my preceptor now and tell her that I believe the patient has ulcerative colitis, but another thing I want to screen her for is Shiga toxin producing E. coli, which I'm going to refer to as STEC from now on. So going over and comparing, contrasting the two, the onset of ulcerative colitis is general over a couple of weeks, and it is preceded by rectal bleeding, usually a month to a couple of weeks before. The onset for STEC from the initial exposure is usually 3 days, but it does range from 1 to 10 days depending on the case. Some risk factors for ulcerative colitis include males being more at risk than females. It's usually seen in ages 15 to 30, but then it peaks again at ages 50 to 80. It is more seen in the Jewish population and less often seen in African Americans as well as Hispanics, and researchers think that this might be more cultural and environmental than actual genetics. We also see risk factors of lack of sleep, NSAID use more than 15 times a month, diets that are high in fat and fiber, specifically fruits and vegetables, as well as vitamin D deficiency, obesity, if the patient has had infection, immunoreaction that's inappropriate, and oral contraception use has been linked to ulcerative colitis. When we look at the risk factors for STEC, it is more seen in the northern US. We're not sure if that's actually because there are more cases or if there's just more reporting of cases, but it is more seen in northern regions. All ages are susceptible to getting this, but mainly seen in 20 to 59-year-olds. And some of the modes of acquiring this disease are food, animal contact, food being fresh produce. Typically beef and pork are the main transmitters, but poultry is also one, as well as non-cooked or non-processed foods. For animals, cattle is the main transmitter of this infection. So anytime somebody is around cattle, it's a major red flag for STEC. Specifically people who have visited fairs, petting zoos, farms, and hand hygiene plays a huge role in this. Nursing home attendants as well as daycare attendants also is a risk factor, as well as some water sources, but these are less often seen. So signs and symptoms for ulcerative colitis, this is really on a spectrum of mild to severe, so people could have 4 stools daily with no blood, up to over 10 stools daily with blood. And you will see that they'll present in more severe cases with fever, fatigue, weight loss, muscle wasting, subcutaneous fat that's decreased, and they could even have dyspnea secondary to anemia, which would also be associated with hypotension, tachycardia, pallor, and malnutrition. Some acute complications of ulcerative colitis that we really need to be on the lookout for as the FNP is severe bleeding that can progress to the patient needing an urgent colectomy. If the patient has fulminant colitis, this can progress to toxic megacolon with systemic symptoms, and this is now not just affecting the inside of the colon, but it's progressed to the muscle of the colon. And toxic megacolon can eventually lead to perforation, and that's going to increase the mortality rate of the patient by 50%. So it's important to look out for these things. The signs and symptoms of STEC, we really go in order with the signs and symptoms. So day 1 is the day that the patient begins the diarrhea. They may have abdominal pain and vomiting, and by day 3, that's usually when the patient will start with the blood in their stool. On days 5 to 13, this is where the most important part of this disease comes in, and that is hemolytic uremic syndrome. This is the biggest reason why it's so important to screen patients with bloody diarrhea for STEC, because there's a 15% chance that they will go the hemolytic uremic syndrome path, which I'm just going to refer to as HUS from now on, and 85% of patients will have spontaneous recovery, and usually diarrhea subsides around day 7. And another thing to look for are low platelets. We should be screening the patient with blood work. And then just to explain a little bit about HUS, the triad for diagnosing HUS is non-immune mediated hemolytic anemia, thrombocytopenia, as well as acute kidney injury. And this is life-threatening, and the reason that we need to screen everyone with bloody diarrhea for STEC. And then looking at some of the tests just to confirm this diagnosis, for ulcerative colitis, it's kind of a combination of 3 things. The patient would need to be having chronic diarrhea, active bleeding upon endoscopy, and chronic changes when the provider takes a biopsy. In the tests for STEC, a rectal swab would be needed to take selective culture, and selective culture is the gold standard. You can also do an immunoassay, but the selective culture is the gold standard for diagnosing STEC. And the most important thing to remember here too is to notify the Department of Health so that we can prevent any other symptoms or cases from spreading. So that concludes why I believe my patient has ulcerative colitis and not STEC.